So I think all of you have downloaded the Kahoot app, and we give you the pin and key the pin to participate. So we are not responding. So please avoid answering calls or keep it in do not disturb me. So we are not responsible for any network errors because many people covered in a small group and position of
loud side. You have to be louder.
Yes. So we are not responsible for any network errors and there are.
Okay. We can't hear at all. It's all so much.
Okay. So the decision of the quiz master would be fine. And,
our quiz masters are Dr. Murli Rajamani and Dr. Deepthi Joshi will be conducting it. And we'll have Dr. Srinivas Joshi asking you all the written questions right to the end. And all the best to you all. Can you?
Yeah, I can.
Yes. Can you explain?
The Kahoot pin is 2221346. This has been posted in the group already. 2221346. And please log in using your mobile number so that it is easy for us to identify.
And at regular intervals, after every 10 points, after 10 questions, keep announcing the results.
That will not be doing.
Huh?
We will not be doing that.
Why?
Anyway, they will be seeing that now.
No, even then, if they know, they can see. But there are some of us who are not seeing. You have to bring that energy into the room.
Cannot be configured at this point.
Why? Last time we don't have Huh? Huh? We all have to thank Microvision for sponsoring this ARC teaching quiz. Have you got your thing loaded? The sign, you have to be very communicative. Unnecessarily dragging it because inauguration will also start.
Madam, he has lost his connection. I think there is some net issue. How many people are facing net issue here? So should we? We don't have any space.
There is no other time slot.
Pen paper.
Huh?
The old pen paper method is what we are asking. We have no option. It's either now or never. If it's now only, then we have to look at it. Nobody has connection. Do people have paper and pen? You have?
We are connected. We are
connected. What is that? See?
Please check. We are connected. All getting connected.
So keep your fingers crossed. Same. Okay. 2221346. I'm repeating 2221346. Everyone has got it? Is everybody connected? Anybody without a net connection?
Why? Why so many of you?
Please recheck. We have no other option. On again. 32 are connected.
You have at least 50 or 60 of them.
More than that.
Connected? No, but if it keeps getting disconnected, how can we do it?
I think pen and paper.
You want pen and paper? No, they can't do it. No, 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 no. Huh?
See, we can have pen and paper. Just
Wait.
how many don't have now connection? Lot of people don't have.
See, Sai, don't show the answer at all.
Don't show the answer, no? See, the sure shot way is have a pen and paper, write your name. We will not show the answer. At the end of it, we will collect all the papers and then we'll discuss the answer. That is the only way. The problem is
The whole system is only way the answer is not there.
hide those PPT, na? It's a PPT, na? Hide those slides. If it goes in between, then we are stuck. If it's a presentation, you can hide those slides.
Wait, look at hide all the answers.
Who's your connection?
Hide this out.
How many don't have connection now?
None of you all move from here. We are hiding the answers. The answers are according to the code. The answer will be shown here. So we are hiding the answers.
One idea is here. We will start.
With your name, paper, and pen, but then
Whoever doesn't have connection, write on a pen paper. We will hide the slides with the answer.
wait, how to evaluate it finally. We have
Mobile number
There's no other.
slide number
we have to correct. Huh?
52 people are connected.
We'll try for 5 more minutes. The plan B is also getting ready. Who are not getting connected, please raise your hand. So there are around 6-7 people.
No.
Try reconnecting it. Try reconnecting it, please.
No, halfway through it gets disconnected.
So plan A will be going on Kahoot. In case there is a disconnection, please keep the papers ready.
Keep the papers ready.
With your name,
Name and roll number.
name and your mobile number. Name and your mobile number.
Phone number.
So that once we evaluate and we can inform you the results.
Do we have papers? Extra papers? Anybody wants extra paper and pen? Just distribute now, please. Whoever wants paper, please take. Distribute paper. Everybody should have a backup of pen and paper.
Only one thing I have.
So everybody has got pen and paper. Check your connections again. Anybody without a connection now? How many are connected? 61 are connected. Anybody without net connection? So that is why we are having a backup of pen and paper. Okay, so everybody has both either
Anybody
net.
got pen and paper? Anybody who gets pen and paper, raise your hand.
Be comfortable so that once we start, then we cannot
Write your
stop in
name,
between.
phone number.
In legible handwriting.
Very clearly block letters because so that you all we are able to contact
Whoever
you.
is outside can please come ahead and sit here, please. So that more people can come in and you all are comfortable. I think it's very uncomfortable standing
Why
outside.
don't you all come here?
Please come in.
Please come and sit here. Don't stand for. Can't stand for.
Come, come.
All this
Space here also.
Remove your slippers and sit down.
Ready?
Answers are written. Let them all come and sit. Come. Don't look at each other's answers. Because we are giving prize only to one person.
Everybody should have tunnel vision now. Ignore your peripheral fields. "20 seconds to answer each question."
Sit down. Remove your slippers and sit down comfortably.
So 65 appear to have been connected. We'll start with this.
Wait. Let us also know that maybe rapidly check how many people are sitting here. Because we should have that many papers we should have received. Because it's a competitive thing. We'll ask them to they say their own numbers from this side and that way. We do it one fast. So that we know how many of them are here. All of you are set. What do they say? We wait 1 minute. 1, 2, 3, they won't say. No, it's not like that. 1, 2, 3, like that, let them say. In 5 minutes, we know how many of them are there. You say 1, 2,
Loudly.
11. That girl, please. Filthy. Do be out if you don't. 19.
Louder.
20, okay, 23. No, it's not 23. 25, 26, 27, 30, 30, she's not there. 30, then 31, 30, 34,
36.
then 41, then goes that. Loudly,
42 now.
loudly please.
45.
47,
Who is 47?
who's 47?
All those who are standing will finish first. 47.
51, 52, 53,
53. Now from the last line. Who is 54? Okay, in this order is nobody else, no? Like this, start from there. 55.
She's 54.
54, na?
She's 54.
You are also there. 55.
55.
Nobody else in that row?
You're not there, madam?
56. 59. Here. 61. Next. 62. 68.
73, here,
3.
73, 74,
83.
83,
So there are 83 of us.
and we need.
How many are? Only 60 are connected.
So we have stuck to do the paper format, and Sai and you have to announce it in the PG group. In the PG quiz group, supervised by us. So 83, we want 83 slips with the name written.
Everybody has it. Anybody who doesn't have, please raise your hand. Everybody has it? Okay.
Would you all write your number also? You all know which number you all said no? Write your number also in the paper. Please write the number on the paper.
Number what you said just now. Serial number.
Serial number.
Mobile number is So shall we start? The PPT is ready without the answers. Answers written. Everybody comfortable? Shall we start?
Wait. Wait.
So everybody settle down. Teacher. Yes, teacher. Everybody has written down their roll numbers. Is there negative marking?
We asked how to die.
Yes.
Even without the mark.
Five for a correct answer and 2 negative for a wrong answer.
2 points. 2 points
Deducted for the
wrong
wrong
answer. And
No attempt, you won't lose any marks. But
if you don't attend, you don't lose
and
marks.
we are taking only 4 choices: A, B, C, and D. If you write 1, 2, 3, 4, it is not automatically translated into. And if the question number is wrong, also you lose the.
Yeah. So if it is A, B, C, D in that, it has to be A, B, C, D written by all. Whatever is written there, it has to be written. You have to also write the serial number which you have said now on that paper. Because there can be no cheating allowed. Don't look at your innocent person.
Yeah, and write your phone number. Your phone number will be the identifier first.
Identify it. Yeah.
Phone number will be the identifier first.
Name and phone number.
So it is 1 mark for every
5
mark.
marks for
marks.
right answer and 2 lost for a wrong answer. -2 for a wrong answer. And no marks for
Not
something
attended.
that is not attempted.
You understood, Sai?
All of you have understood.
Not no.
Yeah. Anybody wants to come and sit here? You can always volunteer. Otherwise, you
Come and sit here. You can sit here on the stage also.
So standing and writing will be difficult.
Okay.
Let's start.
So let's start.
Come here. Come here. Sit here on
We will
this.
be announcing the question. So we will be reading out the question.
We'll be reading on the.
And you have to be loud.
Yeah.
The hall is full. Don't be in a rush.
Yeah, so we start with the trial question. This is entirely a trial question. And
1 minute. Who is keeping the timer? If we have 20 seconds.
he's keeping the time.
Huh. So we have 20 seconds for each question. Okay.
So once the bell rings, we move on to the next question. So this is a dummy question. So don't answer this. So yes. Yeah, we'll say the time starts now, and then after 20 seconds, he will ring the bell, and then we move on to the next question. So this is a dummy question. So exotropia refers to. So I'm sure you all know the answer. So you have to mention in that trial question number 3 or whatever the question number. This doesn't carry any marks, and you have to write A, B, C, or D. If you write anything additional, or you just write A or B, or you write 1 or 2, doesn't carry any marks. Correct answer carries 5 marks, and a wrong answer would reduce your points by 2. And if you choose not to attempt the question, you don't lose or gain any marks. So shall we start with the first question? Okay, so watch this video, and the questions would follow on the video. I have not said the time starts now, so you watch this video. The light off.
नहीं नहीं एक अच्छा पूरा जाएगा.
लाइट नहीं ऑफ करना है. क्या देखेंगे ये लोग आंसर? Look at the people. Don't distract.
So you watch the video, and the questions would follow. So following are true about device shown in video, except what is false about the device. That is what you have to mention. So surface, choice number A, surface area is 250 millimeter square. B, stenting suture reduces incidence of hypotony. C, anteriorly located foot plate helps place anchoring suture more anteriorly compared to barbell glaucoma device. And choice number D is ligature is not required around the tube as there is a stenting suture. So you have to choose the false among all this, and your time starts now.
Please look at the time.
Question number 1. Question number 1. Please write A, B, C, or D. No additional details will be provided. Okay, so we move on to the next question. So this following complication is noted after aqueous drainage implant or glaucoma drainage device implantation. Note this complication, and your choices will come in the next slide. So I'm sure all of you have seen this picture, and now I'm going to the questions. This is question number 2. Following are true except, so you have to again choose the wrong one. Choice number A, can resolve with conservative management. Choice number B, suturing when possible, or if not possible, conjunctival autograft can be tried. Choice number C, the tube should be explanted immediately and the scleral patch graft removed. Choice number D, swabs should be taken for culture sensitivity. So your time starts now, and you have to choose the wrong option among these 4. So you have to choose the wrong option. This is question number 2. So please don't write any other details other than the choice. Time over. So we move on to the third question. So this is complication. Second week post oral aqueous drainage implant, which is also a glaucoma drainage device. So the complication is shown, and the close-up photograph is shown on the right. So I'm sure you know what complication this is. And if you have seen the picture, the questions would follow on the next slide. This is question number 3. So here you have to choose the correct option. Option A, removal of the implant is indicated. Option B, amniotic membrane grafting can be tried. Option C, conservative management with doxycycline. Option D, suturing of the conjunctiva is indicated. So here you have to choose the correct one. Write A, B, C or D. This is question number 3. And please don't write any other details. So only A, B, C or D for this question number 3. The correct choice you have to choose. So we are done with this question. Question number 4. So this is a 30-year-old complaining of oscillopsia for the past 3 months. So watch this video carefully. So you have to watch this video. I'm sure you have all seen the video. So the choices follow. Question number 4. Following are true about the management. A is voluntary nystagmus. You don't need any further workup. This is choice number A for question number 4. B is you need an oncologist review urgently. C is artificial divergence surgery if MRI brain is normal. And D is retrobulbar botulinum toxin if MRI brain is normal. Among these 4 choices for question number 4, you have to choose the correct option. The time starts now.
Close the door. Anybody goes out cannot come inside.
So the correct option, please don't write any other details, only A, B, C or D for question number 4. Whatever is the correct choice, you have to choose that. Okay, your time is over. We move on to question number 5. So this is the second week of post-phacotrabeculectomy. The Aioc is 13, bleb is flat, Cyrils is negative, and the patient had advanced primary angular glaucoma. So you have this clinical photograph here and the UBM to the right. Please watch both of them, and the questions to follow would be from this slide only. So I'm sure you have noted both the clinical photograph as well as the UBM. So I'm moving on to the question for question number 5. So following treatment options can be considered except, so you have to take the wrong choice. A, iridozonulohyalotomy with or without complete vitrectomy and AC reformation. For question number 5. B, steroids and cycloplegics. C is systemic glycerol and mannitol. And D is topical pilocarpine. So for question number 5, you have to choose the wrong option. So your time starts now. So the wrong option for question number 5. Okay, so we are done with this.
So now coming to question number 6. A 56-year-old unilateral glaucoma in the left eye. IOP is 31 repeatedly and he is defaulting on topical medications. OS IOP 31, heavily pigmented angles, normal exam in the right eye. No AC inflammation, not on topical steroids. So, the unilateral glaucoma, IOP is constantly 31 mm of mercury. The angles are heavily pigmented. Rest everything is fine. Not on steroids, no AC inflammation. The right eye is perfectly fine. And this is the anterior segment photo. The perimetry. And the disc photo. So following is the most likely responsible for her unilateral glaucoma. What's the most likely cause? Malignant glaucoma. B. Position of IOL. C. Grant syndrome. D. Pigment dispersion syndrome. So what is the most likely responsible cause for her unilateral glaucoma?
Correct choice for question number 6.
A, B, C or D? So with this we go to the next question now. This is a photo of a glass of a 35-year-old with the right side field defect. So you can see the photo clearly now. True about Fresnel prism which is stuck on the glass are all of these except useful for field expansion. Some position adjustment may be needed to mitigate the diplopia. C. Work by moving image towards the apex. D. Usually low power prisms like 6 to 8 prism diopters suffice.
So the wrong choice has to be selected. The wrong option has to be selected.
About Fresnel prism.
Yeah. Question number 7. Write only ABCD, no additional details.
So hope you have all written the answer. Now let's go to the next question. All are done? So question number 8. This is a patient during examination. So you can see a variable diplopia in the patient. So there are two patient photographs which have been put up, right side and the left side. Now, following are true regarding further initial investigation except anti-acetylcholine receptor antibody testing, single fiber EMG, electromyograph, repetitive nerve stimulation test, RNST, muscle biopsy. So which is not used to investigate further in that patient whose photograph was projected?
The wrong choice for question number 8. The wrong option for question number 8. So remember, each correct choice carries 5 plus and each wrong choice could reduce your point by 2.
If you're in doubt, you can just leave it out. So time's up. And the next question, question number 9. There is a video here. Both patient 1 and 2 have abduction restriction. Look at this patient. And now look at this patient. Both of them are having an abduction restriction. Okay, so now you need to tell us the cause. Following is true. A. Patient 1 likely has paresis and patient 2 has a tight median rectus or median rectus entrapment. B. Both patients have tight median rectus. C. We cannot comment on this without an FDT, forced duction test. D. Neostigmine test can help us diagnose the etiology. Which of these is right about the abduction restriction in those two patients which were shown before?
Question 9, correct option you have to select. Which is the most appropriate option? Question 9. So write ABCD for question number 9. Please remember to write your mobile number on the paper.
And the serial number and your name.
Time's up. And this is your 10th question. Following is true about the use of this modality for managing conjunctival leaks after trabeculectomy. So there is something which is being used in the eye for managing conjunctival leaks after trabeculectomy here. So following is true about the use of this modality for managing conjunctival leaks. Select the correct option. Diameter of around 10 mm suffices. The leak typically seals in 3 to 4 days. C. Will not work in streaming leaks and those more than 4 mm from the limbus. D. It can be used for conjunctival retractions. So which of these is a correct option for the 10th question? A, B, C, D.
Question number 10, the correct option is C. Your time is up, so we move on to the next question. So you have, this is question number 11, you have a 10-year-old with a stormy perinatal period. He has delayed milestones and the vision is poor. So note the fundus appearance. So stormy perinatal period, delayed milestones and poor vision. This is question number 11. Note the fundus appearance. And this is the MRI of the same patient. Okay, MRI brain, non-contrast MRI brain of the same patient. So have a look at the MRI also. The questions will follow on the fundus photograph and on the MRI findings. So I guess all of you have seen the MRI. So now I will move on to the questions. Following defects, this is question number 11, may be seen in this condition. A. Simultagnosia, B. Optic ataxia, C. Prosopagnosia, and D. All of these. So following defects can be seen in this condition and your time starts now. So select the most appropriate option for question number 11. So remember to write your correct mobile number. Thank you. So this is question number 12. So this is a patient with operated trabeculectomy done 5 years back and presenting to us with sudden onset of a red eye. Okay, note the photographs of the two photographs. So if you have seen the two photographs, I'll move on to the options. Following are true, the correct option for question number 12, except. So you have to select the wrong option. If vitreous cavity clear on ultrasound or fundus exam, topical and systemic antibiotics can be tried. Use of antimetabolites increases risk of this condition. Choice number C, Pseudomonas and indole positive protease are the most common organisms implicated. Choice number D, conjunctival swab may be of value in guiding the management. So you have to select the wrong option among these four for question number 12. Time starts now. Okay, we move on to question number 13. So note this appearance, this question number 13. Appearance on gonioscopy after a mixed procedure, minimally invasive glaucoma surgery that has been done. This is the gonioscopic appearance. Okay, taken at around 6 weeks or so. So the question follows based on this appearance on gonioscopy in this patient after MIGS has been done. So you have to choose the correct option in question number 13. Extent of this is related to surgical success, that is choice number A. B is episcleral fluid venous wave is a predictor of success. C. Extent of goniotomy is not important as far as the Aioc control is concerned. And option D, pilocarpine is avoided in the postoperative period. So you have to select the correct option among these four for question number 13. So remember, each correct option carries 5 plus, each wrong carries 2 minus. You may choose to ignore the option if you don't want to answer the question. We move on to question number 14. So this is a test being performed on a patient. So the devices I have shown and also the appearance when a pen light is shown in a dark room. So I'm sure you have all seen this photographs, all the 3 photographs. This is for question number 14. So we move on to the questions based on these three photographs. Following are true regarding the following except. So select the wrong option. A. It is used to estimate cyclotorsion in cyclovertical pulses. B. It can be used in supine position, also to diagnose Q deviations. Option C. Preferably done in a dark room. And option D. More accurate and reliable than using two red Maddox rods. What was shown in the picture is more accurate and reliable than using two Maddox rods. So you have to choose the wrong except. All are true except for question number 14. So we move on to question number 15. So post oral aqueous drainage implantation after 2 years review, there is a sudden drop in vision and IOP is unrecordably low and patient has advanced glaucomatous optic neuropathy. So this is a B-scan appearance which is shown 2 years after RD implantation, oral aqueous drainage implant. So the questions would follow based on these images. So following management options may be considered as the most appropriate initial option. So A. Placing a stenting suture in the tube. The correct option is to be selected. B. Ligating the tube with 6-0 Vicryl. C. Option A plus ligature, temporary or permanent with choroidal drainage, with or without choroidal drainage. And option D. Conservative management. So please select the most appropriate initial management options.
So this is question number 16. A 45-year-old male patient presenting with left eye sudden drop in vision. Color vision is normal. No RAPD presented to us after a month. So you can see the perimetry file over there. OCT angio picture is also there on the left side. Okay. Following initial management option is most appropriate. We give them A. IV parasteroids. B. Plasma exchange. C. Avoid vasoconstrictors, hypotensive episodes and treat atherosclerotic risk factors. D. CT angiography. So which is the most appropriate initial management for the patient whose perimetry and OCTA picture was projected before?
Question 16.
This is question number 17 and you can see a video with the goggles which is being placed on the left side. Looks like a video game. Okay, so now what is this video game which was played with the glasses which was presented on the other side, which represents what? So is it saccadic training? A. B. Is it smooth pursuit training? C. Is it target acquisition training for nystagmus? Or D. Is it dichoptic exercises for amblyopia?
Correct option you have said.
70.
70. Correct option. Right only ABC. Correct option for question number 7.
What is that video game used for? Question number 18. A 30-year-old with normal vision, visual fields and headache So the fundus photograph has been projected.
Please don't go to the next.
Okay. So an MRI image is present below, and venography image has also been projected. Normal vision, visual fields, but there is a 30-year-old with headache. What is the likely diagnosis? Is it a Foster Kennedy syndrome? Is it a papilledema with raised ICT? Is it papillitis? Or is it diabetic papillopathy? A, B, C, D. What is the most likely diagnosis?
Question number 18. The most appropriate or most likely diagnosis is
Okay, just 1 minute. I would have to leave all the very best to you all. Dr. Murli, Dipti, and Dr. Srinivas Sushi are here. You all have to, in a calm manner, give all your mark sheets, and we will calculate it by sometime today night. Tomorrow in the group, tomorrow sometime the results will be announced. Okay? All the best. Congratulations to all of you. I have to go for the inaugurations, but there's more than you can take care of.
So we move on to the next question. This is question number 19. Look at this video. So this is
some procedure is being done.
so it's being closed now. Following is true about the procedure on the lateral rectus. Select the most appropriate response. A. It's profound reversible weakening procedure. B. Can be used in third nerve palsy with nil medial rectus function. C. Can be tried in exotropic DRS with severe co-contraction. Or D. All of this. So that was a surgical procedure done on lateral rectus. So which of these is correct about that procedure? A, B, C or D?
Yes. Good evening, everyone. I'm sure all of you are loving writing it down. Okay. Question number 20. Can you see that figure? So what's that? That's the fundus autofluorescence pictures. 1, 2, 3, 4. Both right eye, left eye, bilateral. Very simple. Right? So the following is true about this 23-year-old asymptomatic patient. Please remember, asymptomatic patient with blurred optic disc margins. Okay? What could be the most appropriate answer? Non-arthritic AION is a possible association. Possible. Has a characteristic appearance on OCT, enhanced depth imaging of the optic disc. Fundus fluorescein angiography is definitely not needed because it is a very clear-cut evidence of FAF or fundus autofluorescence, or whether it is all of these. Please remember, please choose the most appropriate answer. NAION is just a possible association. It's not telling directly, right? Giving you a lot of clues in this. Hence, has a characteristic appearance on OCT EDI. Fundus fluorescein angiography is definitely not needed. All of you. Okay? Good. Next. 53-year-old asymptomatic type 2 diabetic with a vision 6 by 6. I'm again vision 6 by 6. OU, normal color vision. Normal color vision. Motility and pupillary reactions are all okay. BP is 140 by 90. MRI brain is normal. So what's the most likely diagnosis in this case? So this is the visual field of both right and left eye, and select the most appropriate initial management option. Type diabetic control and serial follow-up. Urgent MRV and MRI with contrast. Oral aspirin only, or is pulse steroid needed? Okay? 6 vision, normal color vision, pupillary reactions are normal. Okay.
We move on to the next question. So you have this, note this photograph, clinical photograph, and then note this video of cover test, alternate cover test. So please note it very carefully. Note it very, very carefully, the deviation of the eye under cover. So that's a translucent occluder, so please note for either eye. So you have noted both the photograph as well as the clinical video. So I'll move on to the question. Select the most appropriate response. A. Optic disc drag could cause this. B. Positive angle kappa is likely. C. OD may be embryonic. And D. All of these. So you have to select the most appropriate option. 22nd question. A, B, C or D. We move on to the next question. So this is a clinical photograph. Note this clinical photograph very carefully. Note what the arrow is pointing. So this patient had a late onset after a few years consecutive esotropia after a lateral rectus recession. So the muscle that is being shown is a lateral rectus, and the arrow is pointing to the abnormality. So this is for a late onset consecutive esotropia after lateral rectus was weakened. Okay, so this is question number 23. So what is the likely diagnosis? A, it is a stretched scar. B, it is a slipped muscle. C, lateral rectus bifid insertion. And D, it's a normal lateral rectus. So you have to select the most appropriate, most likely diagnosis for question number 23. We move on to the next question. So here you have a 23-year-old, this question number 24. 23-year-old with right acute retrobulbar neuritis. This is the first episode. Okay, this is the first episode, and note the MRI abnormalities. I'm sure you are seeing the MRI abnormalities here. So this is a 23-year-old, remember, and patient has acute right retrobulbar neuritis, first episode. So if you have seen the MRI pictures, I would move on to the question. Following up, this is for question number 24. Following our management options except, so select the wrong choice. A, IV pulse steroids. B, test for anti-MOG and anti-NMO. C, CSF analysis for oligoclonal bands. And D, discuss disease modifying therapy with neurologist. So you have to select the most appropriate option. That is the wrong option. Wrong option you have to select, which you would not do. For this question number 24.
The front row is empty. Anybody who wants to come and sit here, please come.
So this is question number 25. Patient with findings seen in these images, note these cornea images on slit lamp very carefully. So you have to identify the type of corneal dystrophy. I'm sure you have noted all the images, including the close-ups. So this is for question 25. So, patient with these findings is most likely to have what type of corneal dystrophy? So, please have a look. And so, a patient with these findings is most likely to have what type of corneal dystrophy? Question number 25. So, A. Schneider corneal dystrophy, B. Epithelial basement membrane dystrophy, C. Lisch epithelial corneal dystrophy, and D. Granular corneal dystrophy. So, you have to select what is the most likely type of corneal dystrophy in these patients. In this patient whose slit lamp photo was projected. So, question number 26. You have a 24-year-old woman who presents with ocular irritation, foreign body sensation, reduced vision in the right eye, and findings shown in figure. So, here you have to, of course, identify the dystrophy, only then you can answer the question. What would be the histopathologic examination of the corneal specimen? 26. Option A, amyloid deposit. B, cholesterol and neutral fats. C, acid mucopolysaccharides. And D, hyalin. So your time starts now. Okay. Question 27. The patient came with a vitreous hemorrhage. What is the finding? Which syndrome is associated with the finding? See that hemorrhage. So you have to identify pre-retinal, subhyaloid, subretinal, then only you get it, right? Identify that, you see that sign, you see the shape of that will give you a clue. Now, the patient, what is the finding? Which syndrome? Vitreous hemorrhage, Usher's retinopathy, subhyaloid hemorrhage with Tertian syndrome. Is it a pre-retinal hemorrhage with blood dyscrasias, retinopathy? Or whether it's a subretinal hemorrhage which is secondary to either PCD or CNVM. It's a very straightforward and very easy question. Okay? Okay, you want to see the image? See the shape of that hemorrhage, that will give you a clue. Okay, option. Okay? Done. Next question. What is the name of the biomarker shown in this OCT picture? What is the significance? Please remember the box. Don't see out of the box, see inside the box. Okay? Whether is it a drill, disorganized retinal inner layers, suggests ischemia and carries poor prognosis, or whether it's a CME, because you saw those two cystoid spaces by the side, suggests good prognosis, or whether it is again ORTs, because most of it looked like ORTs, right? So suggest anterior occlusion, none of the above. You want the picture again? I told you so much. Only Murli is a very strict quiz master, very easy. Okay? See the box, inside the box I said, don't see out of the box. Okay, can't give more clue than this. Name the sign on the fundus photo and OCT. Which drug toxicity shows this? When it says drug toxicity, it's very simple. I'm not giving, I didn't answer the drug. Okay, see the OCT. You see under the fovea, the outer retinal layers are preserved. Only the side is disturbed. See the fundus photograph. If I say that, you will get it. I will not say. RP changes in the center in the macula. So, bullseye maculopathy with flying saucer sign indicating hydroxychloroquine toxicity. Bullseye maculopathy with a dipping sign with hydroxychloroquine toxicity. Bullseye maculopathy, the flying saucer sign with a cone rod dystrophy. None of the above. Okay?
Madam wants to see those kids. Okay. This is the OCT. And that is the frontispiece. Okay? Very straightforward. Imagine and write these answers.
So there is an ASOCT scan which has been put up here, and there are some things which have been projected on the ASOCT scan. So identify the diagnosis which is shown in this scan. Is it a DM detachment? Is it a corneal edema? Is it a intracorneal ring segments, or is it corneal cutting? This one. A, B, C or D? It's all done. Question number 31. Identify the diagnosis which is shown in this pentacam image. So you can see the pentacam image over there. It's known as some shape. The anterior, posterior or elevations are given. So let me go to the diagnosis now. Is it pellucid marginal degeneration? Is it Terrien's marginal degeneration? Is it frank keratoconus or is it keratoglobus? A, B, C or D? Pellucid, Terrien, keratoconus, keratoglobus. I told you. So now we go to the question number 32. A 15-year-old male patient came to OPD with the complaints of blurring of vision in the right eye. BCVA in the right eye was 6/9 with those topographic changes what have been shown in on the left side. So what should be the preferred treatment plan? Look at the color coding. Vision is 6/9, but he complains that there is still a blur in the right eye, and that's the topography image. Look at the colors, green and red, and now identify the diagnosis. Is the treatment a topography guided PRK with CXL, collagen cross linking, DALK, observation? Many of the PGs are leaving so many questions blank. It's just -2. Attempt कर लो. कौन सा life and death का सवाल है? Just attempt it. When I sat there, I saw the paper totally blank actually. It's +5 -2. So there is lot of chances that you will get +5. So let's go to the next question now. That is question number 33. So you see something over there which is straightforward. Okay, everybody knows this. Which of the following occurs with the condition which was projected in that figure? The steepest meridian of the cornea is adjacent to this lesion. B, these are benign with no malignant potential. C, they can grow rapidly. D, patients may also have congenital cardiac defects. So which is correct about the condition which was shown to you before? Is it A, B, C or D? The image was very clear. Anybody wants to see it back? Okay. So now question number 34. You can see something over the cornea over there. Concerning the patient in figure, after what number of incisions does the dioptric effect per incision decrease significantly? So you are seeing some incisions over the cornea. How many incisions should be given so that the dioptric effect per incision decreases significantly? Is it 4, Is it 8? Is it 16? Or is it 32? What is the number of the incision which should be given? To make the result significant. So I hand over the mic now. Remember, +5 minus 2. Don't leave the question.
Move on to question number 35. So see the fundus picture and the fundus autofluorescence, and you have to identify the gene involved in this disease. You see the fundus photograph and also the autofluorescence. Question number 35. So the options are A. ABCA4, B. PRPH2, C. BEST1, and D. TIMP3. So you have to select the correct option. Most likely gene which was involved with the fundus appearance that was shown. Okay. So these are the genes. So if you have selected the correct option, then move on to the next one. So what should be the walt size in pachychirals? A. Half to 1 1/2 of corneal thickness. B. 1 1/2 to twice of corneal thickness. C. Twice to 2 1/2 of corneal thickness, or D. 2 1/2 to thrice of corneal thickness. What is the walt in pachychiral? So your time starts now. Question number 37. So you have the B scan of a lesion that was seen on fundus. You have to see this and you have to tell what is the most likely diagnosis. So the option A, Colestat appearance choroidal melanoma. Option B, dome-shaped heterogeneous mass, choroidal metastasis. C, dome-shaped homogeneous mass, choroidal hemangioma. And D, none of the above. Want the image again? There you go, that's the image. And these are the options. So question number 38, you have a 32-year-old female who came with diminution of vision, redness, pain and watering in the right eye for 15 days. You have the clinical photo and the confocal microscopy image, and she is a contact lens wearer. So you have to identify the organism that is most likely to be causative, noting the confocal picture as well as the photograph of the cornea. So you have to identify what is the organism that is most likely to be causative. So option A, fungal keratitis, B, Pseudomonas keratitis, C, Acanthamoeba keratitis, and D, microsporidial keratitis. You have to identify which is the most common one. We move on to question number 39. So note this clinical picture. So note it very carefully. So note this clinical picture, this and this. Okay, 3 ocular motility diagrams in the horizontal plane. I should have put it horizontally across so you know what is restricted. And then these are the MRI images that are shown here. Okay, because the diagnosis is a little obvious, so I did not give you much of the history. But then I could tell you something here where my arrow is pointing, that is the abnormal area, it is not seen here. So the lateral rectus goes through some kind of a canal, sorry, the sixth nerve goes through some kind of a canal. So the diagnosis, option A, Grady-Negro syndrome, B, internal carotid artery aneurysm, C, pontine glioma, and D, normal MRI. So you have to select the correct option. And you have only 2 more questions to go. So remember, each correct answer gives you 5 plus, and each wrong answer gives you 2 minus. So only 2 more questions. So question 40, what is the diagnosis in this picture? So note this fundus appearance and you have to mention the diagnosis. Option A, serpiginous choroiditis, B, serpiginoid choroiditis, C, multifocal choroiditis, and D, frosted branch angioitis. I go back. Picture. Yeah.
It's a very clear-cut answer. Very clear-cut answer. Huh? You got it? Thanks, sir. Huh? One more question is there.
Last question.
What is the etiology? What we see this horrifying fundus picture. What is the etiology of this picture? Yes? Whether it's a CMV retinitis, a toxoplasmic retinitis, SLE retinitis, or all of the above. Please remember, the patient is immunocompromised. Think that the patient is immunocompromised. Please don't take it. Immunocompromised patient is on steroids or immunomodulators. We don't know. So what are the diagnoses? Whether it's CMV, toxoplasma, SLE, or all of them.
So we collect the papers.
Okay, please hand over your answer sheets. Best. No, please sit there. We are collecting roll number wise. Yeah.
Acknowledgement to some of my colleagues who have given some of the questions are recorded patients.
Okay, don't make noise. They are all professionals. So how was the quiz, madam? No, it will be nice only. But what is the medium of complexity? Easy, medium complexity, tough. Moderate. So next time we should make it little more harder or easier? Harder. Huh? Sure? What's the time? You can put it on the group. Huh? 5 minutes. Yeah, that's what. Once they collected, we'll start from 50. Question 50. Sorry, question 40. 41. Everybody give your papers. Once they come on the stage, then nobody will be able to give their papers because we are discussing the answers. And what if you recorrect and tell it again? Like 3 idiots, what happened in 3 idiots? He put the paper and then he jumbled it up and he ran away. Ran so. So that cannot happen because all of them are coming. Hey, please don't go. We are discussing the answers. Just 10 minutes will quickly. We'll run through. Those who are not interested can go. Everybody has handed over their papers. Who hasn't handed over, please raise your hand. Okay, LOC madam. Please, this side, you come. Once it's collected, everything is collected. All done. So don't collect any more papers if they give madam. Time is up. We'll go to 50. Question 50. You want to go from first?
Okay, so all of you know what this device is? All of you know what this device is? So you know it's a clear path device. So the following are true in this video except ligature is not required as the false answer. Okay. So except, so that is choice number D should have been your answer because ligature is actually required because it's a non-walled device. So this is the conjunctival erosion after GVD implantation. So conjunctival erosions can actually be managed conservatively, and following are true except it can resolve with conjunctival conservative management, and you can try suturing if the defect is small or some kind of an autograft can also be tried. Tube should be explanted is the wrong answer. That is the correct choice in this. So you still could resolve conservatively, and swabs should be taken for rupture sensitivity. That's also correct. So the choice for this question should be C. So this is the wrong thing. Tube should not be explanted. So you could still get it, but here this question is second week post study. You have a plate exposure. So once the plate gets exposed, the obvious choice is to explant the device. Some people have tried a tarsal-conjunctival graft. Doesn't maybe tried, may not be, but the first choice is you have to take the device out. So the correct choice is removal of the implant is indicated. Okay, so removal of the implant if there is a plate exposure. And this is a very classic video. This is actually ocular flutter. This is actually ocular flutter. If you see the defoveating movement, both are fast movements. Okay, nystagmus, one is a slow and one is a fast movement. So both are fast movements. So it is not voluntary nystagmus. And the correct thing is you should immediately get an oncologist opinion. Okay, an oncologist opinion is in order. So this is something that we as ophthalmologists can identify. And sometimes you have even diagnosed a hypostupidity. So it is not voluntary nystagmus because both are fast phases, both are fast movements, and you should get an oncologist review. The rest two are totally useless. Especially MRI brain is generally normal because the malignancy is somewhere in the lung or in the GI. So the correct choice is oncologist review. MRI brain will be normal. The C and D are just misleaders. So oncologist review is what you should do. So this is second week post trabeculectomy. So note that the IOP is in double digits. Okay, so immediately when the IOP is in double digits and you have a shallow AC, you either think of suprachoroidals or you think of malignant glaucoma. So if you see, this is the UBM picture and the ciliary body is actually directed anteriorly. So this is an aqueous misdirection syndrome. So again, another clue that I have given is more common in advanced primary angle closure glaucomas. So the AC is shallow, the IOP is in double digits, and you have a ciliary body that is pointing anteriorly. So this is aqueous misdirection syndrome. And so pilocarpine is contraindicated in aqueous misdirection syndrome. So the pilocarpine should not be used, and D is the correct answer. Okay, and this question 6 unilateral glaucoma IOP 31 are heavily pigmented angles. So it is unilateral and there is no AC inflammation. So if you notice here, this is a single piece IOL placed in the sulcus. So whenever a single piece IOL is placed in the sulcus, it will throw out a lot of pigments. So that is what is causing the glaucoma. It is not a primary pigment dispersion syndrome. It is actually the position of the IOL. The position of the IOL is the correct answer. Okay, the rest are just dummy questions, dummy choices. So, not have any comments. So, this is a 35-year-old with the right-sided field effect. So, right homonymous again. So, you've given a field expansion Fresnel prism. Usually, these Fresnel prisms have the order of 30 to 40 prism diameters, and you give a cutout for the fovea. You don't want to blur the fovea. Anything about 12 will actually cause a lot of blurring. So, this is a field expansion device with Fresnel prism. If the patient has a right homonymous immunopathy, you stuck it base out in front of the right eye. If it is a left homonymous, you stuck it base out in front of the left eye. So it's a high power prism. So this is the wrong answer, except. So low power prisms are of no use, 6 to 8 prisms. Usually you would require 50 to 40 prisms for meaningful field expansion. So the rest are correct and this is the wrong answer. So this is a highly variable process if you notice. So extremely variable process. This can only be because of myasthenia. Okay, and diagnosis is myasthenia even without you doing anything else. So note here left eye ptosis at one point of time and the other right eye ptosis. And I have actually put this hand here so that frontalis action is completely mitigated. So this is during the exam the ptosis gradually increases. So this kind of variability almost, but I still put it as an initial investigation. So anti-ACH receptor antibody testing, yes, definitely. Single fiber EMG, RNST, they are all investigations done for myasthenia. Muscle biopsy may not be indicated because you are clinically thinking of myasthenia. Just to avoid controversy, I put it as an initial investigation. So muscle biopsy is the choice that is because it is Excel. So this, if you see, this is a floating saccade. Okay, this right eye movement is a floating saccade. The eye tends to move out very slowly. There is an abduction restriction, but the eye is moving out very slowly. Whereas this is a tethered stop. It happens in a restriction. Note that the speed of eye movement during abduction is good, but it is as if something is suddenly holding the muscle like a leash. Okay, so the right eye is a paresis and the left eye is a restriction. That is the correct choice. Right eye is a paresis and the left eye is a restriction. So you can definitely comment without an FBT. In fact, saccadic movement clinical observation is helpful in children where you cannot do this. And neostigmine test is a dummy. So this is the correct choice. So this is a bandage contact lens used for managing small conjunctival leaks. Okay, focal conjunctival leaks after trabeculectomy. Usually 2 to 3 weeks of application is required, and it will not work for streaming leaks. 10 millimeter is the wrong choice. You usually use 14 to 16 millimeter, and the leak takes 2 to 3 weeks to seal, and definitely it cannot work in streaming leaks or only with focal pinpoint leaks. It could work, and if the leak is more than 4 millimeter, the contact lens will not reach there. So more than 4 millimeter from the limbus is not an option. Streaming leak, it won't work, and if there is a conjunctival retraction, you have to go back and see. So leak takes 2 to 3 weeks to heal, and 10 millimeter is useless because it will not go beyond the contact. So the correct choice is it will not work for streaming leaks and more than 4 millimeter from the mask. So this is a very classic picture. 10-year-old with stormy perinatal period, delayed milestones, and poor vision. Patient has bilateral optic atrophy, and this is also a very classic appearance. If you notice, there is dilatation of the ventricle with gliosis of the occipital lobe. There is hardly any white matter here. So if you notice here, this is the dilatation. It is called, there is a dilatation and splaying of the ventricles. To distinguish it from hydrocephalus, because the temporal horns are not dilated. Hydrocephalus and the temporal horns will be dilated. And anyway, there is this occipital gliosis there. So this is a patient with cerebral visual impairment, and all these effects may be seen. Simultagnosia is if you present to him a car and you present a tree, patient will be able to identify it separately. But if you put it together, he will not be able to piece it together. Optic ataxia is some kind of a staggering movement in target acquisition. Prosopagnosia is a difficulty in identifying faces, and all of these are seen in cerebral visual impairment. So choice D is the correct answer. Choice D is the correct answer. So this is a blood-related endophthalmitis, a blood-related infection. So that's why I put 5 years, but it's a late onset. Usually it is caused by the commensals. So indole positive protease and pseudomonas will be iatrogenic, but late coming after 5 years, they are not generally the most common organisms. So vitreous cavity is clear. This is correct. Conjunctival swab is used, and use of antimetabolites also increases risk of this condition. If it was an early, I would have thought of pseudomonas and indole positive protease. But if it is a late thing, it's a coagulase negative strip focus, and the commensals usually cause this. So this is the choice C. This is the wrong choice. So this is appearance after GAD. This appearance, if you notice this gutter-like thing here, it is a trabecular shelf. Okay, the extent of trabecular shelf, it doesn't correlate with the success. But what correlates with success in GAD is the appearance of episcleral fluid venous. So the episcleral fluid venous is the correct answer. Pilocarpine is actually given in the postoperative period because you don't want the iris going and sticking there and blocking in the trabecular shelf. So choice B is the correct option. Choice B is the correct option. Episcleral fluid venous is the correct choice. This is a double Maddox rod test being done. Earlier it was done with a white Maddox rod and a red Maddox rod. Later on, 2 red Maddox rod is said to give less of a false responses. So sometimes this use of white and red Maddox rod localize the extraction to the normal eye. So the correct choices, you always use 2 red Maddox rod, which is more accurate. The rest is correct. Actually, supine position is Q deviation, the torsion will go away. So that is how you differentiate between skew deviation and superior oblique loss. So choice D is the wrong choice, which has to be selected for your answer. So more accurate and reliable is wrong. It is less accurate and reliable. So this is a kissing choroidal after RD 2 years later. So whenever you have something like a kissing choroidal, you have to go in and drain. And drainage alone will not suffice. You have to put a stenting suture in the RD, and you also have to put a temporary or a permanent ligation. So here the more evil is the hypotony because the pressure is unrecordably low, and this kissing choroidal will not go away even if you drain it. It's going to come back again. So you have to drain it, of course, but you also have to do something for the hypotony. So choroidal drainage was there only an option. See, sometimes putting a stenting suture will work if there is a chronic hypotony maculopathy, but when there is a kissing choroidal, you have to do a choroidal drainage with a temporary ligature and So this is a very typical non-arteritic. I mean, it is a ischemic optic neuropathy, most likely non-arteritic. If you see the OCT angiography, so you see the superior capillary loss here. Corresponding, there is an inferior altitudinal field. Okay, and specifically I mentioned it presented to us after a month when the disc edema is resolved. So very typical ischemic optic neuropathy only, especially because the OCT angiography picture is correlating. Superficial capillary plexus is lost here. There is an inferior altitudinal field defect. So management of atherosclerotic risk factors if a hypertension to avoid vasoconstriction, that is the correct choice. CT angiography is not going to help you here because the vessels are so small they can never be seen on CT. So yeah, this is actually a dicoptic exercise. So if you see, if you wear the red and blue glass, you can play the game because you are splitting the game into two. So one eye will see the blue, blue tank, and the other eye will see the red cars that are approaching. So this is a dicoptic treatment. Dicoptic is you can play the game only when both eyes are used together. You split the game into half either with a 3D goggle or with a red-green glass. So this is called an anaglyph glass, red-green anaglyph glass. So you split the game into two. So this is a dicoptic treatment for amblyopia management. This is a proprietary software by Knox. So I didn't put it because we don't have any financial interest here. So dicoptic exercise is the correct answer. So this is a classic papilledema. So here there is a transverse sinus stenosis, which is often a common finding in patients with Aioc. What is important is you have a subretinal fluid here, and the Brooks membrane is pointing inward. You have flattening of the posterior sclera, no implicating lesion, and disc edema. So I have already mentioned normal vision and visual fields. So you have disc edema with normal vision and bilateral listening, and headache also. You are thinking of IIH only. Foster Kennedy is not the option because one disc is not really pale. So papilledema with raised ICP is the option. Papillitis, if there was a vision drop, you would have thought of it, but vision is normal, which we specifically mentioned. So papilledema with raised ICP, and the Brooks membrane is also pointing inward. So this is actually a lateral rectus deactivation. You suture the lateral rectus to the orbital periosteum. So you have secured the lateral rectus, and then once you have exposed the orbital periosteum, you prolapse the lateral rectus out, and you are securing the lateral rectus to the orbital periosteum. So you would do this kind of a profound weakening procedure. It's a profound, potentially reversible because you can, of course, go and get back the lateral rectus also. You would do it only in the following condition. It's a profound reversible weakening. You can use it in third nerve because none of the other muscles are working. So whatever you do to the medial rectus, it is not going to work. It's tried in exotropic DRS also, and all of these is the correct answer. So it's a lateral rectus periosteal fixation or a lateral rectus deactivation. So all of these is the correct answer. This, of course,
Yes, let them answer. Very good. Optic disc drusen. Very simple answer. So NAIM could be a possibility because it can cause the pressure on that, and has a characteristic appearance on the OCT. If you do a EDI on the OCT of the optic nerve head, definitely fundus fluorescein angiography, as I kept on telling, is not needed because the FAF is already showing the drusen autofluorescence, and so answer is all of these. Very good. Next. Yes. Anybody? What's the diagnosis?
So if you notice, the left eye is the edematous disc, whereas the field effect is on the right eye. If at all you wanted to say.
Yes. Yes. Diabetic papillopathy. That's why you see the vision 6/6. Though patient is having this edema. So what will be the answer for this? Next, sir. Pulse steroids. Hey, already diabetes. You send him up. So it is just tight diabetic control with serial follow-up because it's a diabetic papillopathy. It's a benign condition. Vision loss will be not there, and color vision. as I kept on telling. So if the color vision was this thing, then you should have suspected optic neuritis, and then pulse steroid would have been required.
So this is a pseudo-exotropia actually, positive angle kappa. If you notice on cover test, the right eye seems to go up a little bit. So there is a right DVD, it's not seen on the left side. Okay, but other than that, there is no horizontal movement, even though the brushbug would indicate that there is a exotropia here. So the correct answer is optic disc drag can cause this, positive angle kappa is likely, and right eye is amblyoptic because of the DVD. So the correct answer is all of this. So this was the fundus appearance actually. And so this is actually a stretch scar. I have specifically put late onset. I even mentioned that 5 years later. So if you notice here, there is a fleshy muscle here, and there is a sharp step where you see the pseudotendon. So this is actually a stretch scar, not a slip muscle, because slip muscle was present earlier on. Okay, so anyway, the appearance is also very characteristic of a stretch scar. So this is actually a right eye retrobulbar neuritis. You see these demyelinating plaques here. What are they called? Dawson's fingers. And what is very difficult here, if you see the small ring here, if you see this small ring here, this is an open ring sign, very specific for multiple sclerosis. So the thing is, if you have MRI evidence of multiple sclerosis, then you don't need to do anti-Morgan NMO antibodies anymore. So everything else is correct. CSF analysis for oligoclonal bands is required because that is what is multiple sclerosis. So this is the first episode, so you will discuss it with the neurologist. Anti-Morgan anti-NMO is not required because the MRI is very much suggestive of multiple sclerosis. The open ring sign and the Dawson's fingers are very specific for multiple sclerosis. So, this you should need not do. Okay, this all of you know this is a granular dystrophy, and because the cornea in between is clear, so this is a granular corneal dystrophy, and scrum-like appearance. So this is a macular dystrophy, and so you know that acid glucopolysaccharide is what.
Yes, shape. I kept on telling. Boat shape. So that's the subhyaloid hemorrhage, right? If there was a subretinal hemorrhage, how would you differentiate? The vessels, O-line vessels could have been seen. Here it is not seen, right? And the shape, typical shape of it, it's a subhyaloid hemorrhage. So what is it? Tertiary shape. Yes. Drill. Very easy. It looks like an ORTs, or sometimes you might get confused with pseudocystoid spaces or cystoid spaces. But these are not. This is basically a cystoid space in a drill patient. Drill is disorganization of retinal inner layer which carries poor prognosis. So the patient has to be explained that even after anti-VEGF or the steroid therapy, the patient will not be getting good vision. And in these kind of chronic macular edema cases, these are, right? So in these cases, the steroids, that is dexamethasone, is more preferred than anti-VEGFs in these kind of cases. Yes? Flying saucer sign, right? So you see, I kept on telling them. So what happens here? You see, there is loss of the ellipsoid zone. Only the outer retinal layers below the fovea is preserved. So there is a perifoveal lesion, what we call it, and the fundus shows bullseye maculopathy. That is the RPE disturbance you see there, and that's why it's called as the hydroxychloroquine. What's the maximum dose of hydroxychloroquine? Usually around 200 to 400 milligram per day. If it crosses more than that, then there are signs of hydroxychloroquine toxicity.
So this, you know, it's intracorneal ring segment. Intracorneal ring segment. You can see holes here. Intracorneal ring segment is the correct. So this is a pellucid marginal degeneration. I mean, again, not my specialty. So pellucid marginal degeneration. And preferred treatment plan: stromal-guided PRK plus CXC. These are multiple corneal dermoid. So actually, the area adjacent to the dermoid has the maximum flattening. So these are benign with no malignant potential. They don't grow rapidly. Benign with no malignant. What? Malignant. Yeah, I know they So golden heart doesn't typically have congenital cardiac disease. It can have. It's not wrong. So this is an RK and more than 8 reduces the more than 8 incision. So this is Stargardt gene, Stargardt disease, and APGA4 is the APGA4 is the
What is ABCE4? Okay, and what does PRPH do? PRPH2? What was it earlier? Earlier it was called as retinal degeneration slow disease gene, RDS gene. Now they have changed it into PRPH2. What does it cause? Yes, some kinds of pattern dystrophy or even autosomal dominant retinitis pigmentosa. And what was the other gene? The best you all know? Bestrophin. Bestrophin 1. Yes, Best disease or vitiliform macular dystrophy. And last is TIM. Sorsby fundus. Very good. Sorsby.
correct answer is APGA4. And vault size should be half to 1.5 of 1 year. The rest was a straightforward question. Half to 1.5 of 1 year.
Is it heterogeneous or homogeneous? Homogeneous. So it's a dome shape, right? So it's a dome shaped homogeneous choroidal hemangioma.
So okay, again, very good. Yeah, so this anybody got it right? Yeah, grading. It's a serious patient has a right sixth nerve for the right abduction restriction. And if you notice this, sorry, I really didn't put that ear discharge because that would have made the diagnosis very, very obvious. So if you notice here, this is the petrous apex, which is why I did point to this. So Dorello canal is where the sixth nerve travels through. So it's a petrositis. It's a petrositis with I did point to this. This is the abdominal area. You see, it's not seen on the left side. So Gradini-Go syndrome is the correct answer. So
Serpiginous choroidopathy, serpentine pattern, right? Of course, if it would have been, we have given both the thing, then it would have been really good because it's a bilateral disorder. And what is the treatment for the serpiginous choroidopathy? Heavy steroids, not just steroids. Heavy steroids because it progresses very fast and it usually carries a very poor prognosis. Any intravitreal injection can be tried in this. Have they tried any intravitreal injections? Hey, not Augustine. Huh? IV prednisone. Methotrexate has been tried. Intravitreal methotrexate has been tried and many other kind of intravitreal agents which are basically the biologicals or immunomodulators are tried. Yes, last question. Huh? CMV? Anybody else? All of the above. That's why I kept on telling. All of the above because it can happen even in the SLE retinopathy also. It can happen in toxoplasmic retinitis, but it's rare because usually toxoplasmic, what happens? You see headlight, the fog appearance. So there's dense amount of vitritis. But these were showing the picture more of vasculitis pictures, right? So it can be an SLE, it can be toxo, or it can be a CMV. That's why we said the patient might be immunocompromised, or the patient must be using some immunomodulators or any of these kind of disease where these kind of very bad vasculitis reactions can happen. Okay? So I would like to thank Dr. Muji sir, Dr. Deepthi, and our ARC gems, Vel Murugan and the entire team. Dr. Tamil is here. All the ARC team. I am really thankful to all of them. Hope you enjoyed the quiz. So next year we will come out with something more interesting. And thank you, Dr. Kirti Madam, for gracing the occasion as the chief guest for this quiz program. Thank you.